Last and most excitingly, we get once again to hear from Sheryl. By popular demand, I hear that she's been here 19 straight years, so congratulations. Sheryl's a seasoned equities analyzer and reporter on what's happening in the capital world of health and healthcare. So please welcome Sheryl.
Okay, folks. Well, first of all, thank you for staying. Once again, Paul, Margaret, Paul, we love this conference. It is unique and made all the more special by both of you, especially Margaret, sorry, Paul. And thank you again, because this really is a family event of people who have seen us all mature and change in our careers, experience different political administrations and different and then the same and then different iterations of the same issues in healthcare over and over again. So I don't really know why you need me up here to tell you things that you've already lived through, because we've already lived through them, but I'm going to try anyway and put a little bit of a different spin on it. But this time I do really think that the world is extraordinarily different. It's not normal, and it is a world in which we have introduced a chaos element that makes my job all the more difficult. I live in a world where you give me a plan, I model out what it means, and then I tell you whether to buy or sell or stock. If I'm really good at my job, and that might be on a Tuesday in March in 1998, but might not have been, if I'm really good at my job, I can actually predict the future. I can take the information I have today and I can make certain inferences and connections and extrapolations and predict what's going to happen to a company, its earnings, its cash flows, its stock price. And to do that, I've always had to look at the political element in healthcare because, as we know, we can always count on our dear partners in Washington to whack us upside the head and tell us something different is going to happen tomorrow that we didn't expect. And that's the environment that we're in. So the title of today's presentation is The Chaos Factor, the Price of Trump. So in case you were wondering about what I think about sort of what's going on, you're beginning to understand. So we're going to start as we usually do. We're going to take a look back at what happened, and I'll give you my views. So that was me. At 3:30 in the morning of November 9th, downgrading my entire group. Boy, was I wrong. But that was me. So what happened in 2016? Well, there were a couple of things. First of all, what I want to point out was that this was the year of the tweet and tweets move markets. So the white line that you were looking at is, this white line is the Healthcare Services S&P stock index. I cover healthcare services, so that's why we're looking at this. And you can see that, you know, as you approached the election here, this was election day before, this was the election morning, and zing, Trump effect, okay? And, you know, this is a chart, by the way, on January, back here in January 1 of 2016, you should have bought this market. Up and to the right is good, okay? But you shouldn't, you know, you had a really deeply painful earnings-driven fourth and first quarter here, and then boom, the services index really took off. Okay, so part of this was being led by managed care, not so much by hospital land, which I cover, and absolutely not by post-acute care. And then, of course, we have this misery here of the way down, which was very short, lasted all of about a day. Maybe a day and a half, and then the market certainly recovers. So now let's take another look at what this looks like. Okay, so this is, I'm sorry, that was the overall healthcare index for S&P, and this is the healthcare services index. I apologize. So now, I titled this, well, she may as well have won, because this was the market anticipating a Hillary win in healthcare services. And why was that important? Because healthcare services are hospitals and managed care companies on the front line of impact of what's going to happen with health reform. Okay? So obviously now this is where we come to in November. We're leading up to, you know, the view that a GOP triple play in Washington is going to be dreadful. This is repeal. Okay, maybe it's replaced, but it's repeal, and this is what the market was telling you on the day after the election in the next 3 seconds, and then zing, right back up again, okay? In addition, we have pharma. So this is kind of a new slide, so I'm not a pharma analyst, but I sure understand what happens when governments get interested in price gouging as a consumer-driven issue and their phones light up, okay? My kid's EpiPen just doubled in price. This is not a good call to get, okay? And certainly as a manufacturer, it's not a call you want to have made to your congressman or woman, to the extent they still let us in Congress by the time Trump is done. So, and oh, by the way, am I dressed as a woman? I'm in the, I thought about wearing black, but then I decided to wear white because like the Queen Mother, Queen Elizabeth, who had to go on a trip to France after an unfortunate death in her family, she was told that white is also a color of mourning. Okay, so now, we're on a roll now, so we're going to keep going. So, Hillary tweets. She tweets a couple of times, actually. She tweets here and says, she won't be able to do anything. What can she do? I said, yeah, but guys, this is the beginning of the end. You should be careful here. Okay, we've seen this act before. And then, of course, we get the peak, and she tweets again, and then zing, all right? Now, one of the interesting little things here is she loses, and look what happens to pharma. I mean, this is daily pricing, so that's 1 day, 2 days, 3 days. The index goes straight up, and then it goes straight down, okay? Because between here and here, Trump tweeted, okay? And then, sorry, my arrow's in the wrong place. It should have been right up here. And now it comes back up, and then from here to here, it's the impact of the Trump press conference. Okay, they're murderers, or whatever it was that he said. Who remembers? Okay? He's the only president of the United States. So this is what is going on here, okay? Again, the SPX is the S&P 500, and the white line is what's happening to pharma. That's the index. All right, but sometimes the issues were actually company-specific. This is one of the favorite stocks that people think I like to pick on, but I'm just absolutely stunned and amazed. It's not often you see yourself be right, but there you go. So community health systems is a consolidator of non-urban healthcare systems or hospitals, okay? And they had the unfortunate opportunity to buy Health Management Associates, which was a similar kind of organization, which in my opinion and later borne out was deeply flawed, and now they're paying the price for their appetite. Here we go, underperforming, and massive losses in terms of massive underperformance relative to expectations. Missing EBITDA by $100 million a quarter on a base of $500 million is not a good thing. So you get this long term from 2015 mid-year all the way down through 2016, and then this most recent quarter, they got us. They finally performed in line with expectation and caught us all with our pants down. So good for them, but it wasn't cash, so therefore I have to wonder whether or not it was real. Doesn't matter, stock's going to go up. You can't see how much it's up, but this stock was up 40% in 1 day. Okay? So this is what happens over the longer term when you make bad acquisitions, when you spend money and you don't generate cash flow or volume-driven cash flow, and that's one of the things that happens. So that was a company-specific issue. They're working on selling assets and trying to get out of their own way, and they may actually succeed. I've actually come out, said officially, to credit and equity investors, don't start your conversations with me, the company's going to have to file bankruptcy, because I absolutely firmly believe that they have strategies that can prevent them from doing so, but it's not going to be easy, and you can see that in the stock price. So that's a little bit of the view on that. And facility-based post-acute care, if you remember when I was here last year, remember I said right place, right time, right reason, right cost. All of that's not good for post-acute care. The slide's in here again. I'll do it again, but just in case, because it's still true. But it really wasn't good. So this is the post-acute. This is Kindred equity in the white line, and then I mapped against it moving averages for it, as well as stock price charts in the green for Genesis, another post-acute provider that's having some difficulty, and then in the purple is Ensign Group, who had been actually doing fairly well, taking facilities with star scores of 1 and 2 and making them into 4 or 5, which seems to be the trick here, that quality actually matters in the post-acute world. Even those of us on Wall Street can see that. Okay, So what are some of the issues here? So, you know, I've been pretty worried, and I've been pretty wrong, and I've been pretty negative on the impact on healthcare services, predominantly on hospitals, of having a Trump administration with a Republican-controlled House and a barely but still Republican-controlled Senate. And my view, when you know, the election results became unfortunately blindingly obvious, that we were going to go into a period of, on the one hand, full employment act for healthcare services analysts, because guess what? Wall Street calls on us to explain what's happening in the Washington world, as well as what's happening in the greater provider and payer world. And so there's lots happening, we have jobs. But the point here was that my view was that if the Republicans were smart, they would have learned from what happened with the ACA to begin with. Obama had political capital. He could have gotten this thing done in less than a year. He waited around for the marginal votes, the Senate waited around for the marginal votes of Collins and Snow, begging, pleading, pushing, pulling, adjusting, poking, and prodding. Okay? The House was all the way mostly on the left anyway, but Pelosi, to her credit, had enough control over them that they wanted reform, they knew it was on their agenda, they would pass pretty much whatever the Senate sent to them. So getting it done in the Senate was the key, and it took them a year, and they lost the 60th vote. So, not that I want the Republicans to read my reports and take my playbook, but if I were them, that's what I would have done. I would have gone in right away with a plan, you know, a man, a plan, Panama. Go in with a plan, get it done, get it passed, while you still have that political agenda, and then figure it out from there. So you should have known repeal, you should have known replace, and it should have been there. And oh, by the way, if you really wanted to get this thing done and you didn't have 60 votes, you could have used the super nuclear option of getting rid of the, essentially the sequester rule. The filibuster rule. Just get rid of it. Just suspend it for a while. You can always put it back in, okay? If you really want to do that, you could have even made it that much easier. And I thought the Republicans were this incredibly solid voting bloc. So if I was wrong, I'm happy to say, I was wrong on that point, that they're not. And that's one of the things that I learned here, and I'd want you to take away from this, is that they're not a solid voting bloc. As you know, the most important thing I heard at this conference was Wendell and the committee on the panel yesterday, and then backed up by Boehner sort of laughing into his tweets, saying, it ain't going to pass the House so easy, guys. The Republicans can't agree, because the wings of this bird have no center, okay? So this is the issue that concerns, you know, that is a concern. And if the best case for health care is the status quo, and the status quo is a bunch of broken individual exchanges, but maybe they still can get something done to squeeze down on Medicaid spending so that they can satisfy the Freedom Caucus and whatever their view is of people who are unfortunately a little poorer than some of us sitting in our seats, to be able to access health care. Okay, so maybe we still get the kind of worst of all things where the only thing that's working from a coverage perspective in the ACA, which is the Medicaid expansion, they also eviscerate. And they do it in the name of budget savings. We're still at risk for that. But the thing that made me most happy from this, and I think the most important thing that I heard, was that, yes, the Senate, we understand the Senate's going to be very difficult, and whatever extremism comes out of the House will have to be revamped by the Senate, because that's, you know, those marginal 2 votes, okay? But in the middle of all of the rest of that is this notion, very important, that the less extremely conservative versus the more extremely conservative parts of the House, Republicans, may not be able to be brought together to pass a bill. So that's important. So now the question is, what else can Trump do? So, okay, I'm going to get into that in a second. What he can do and what he's done is he's put out some executive orders, okay? Then beyond that, the market, my world, has said, oh, it doesn't mean anything. And even some of the folks that we sat around talking about this will say, oh, the executive order doesn't mean anything. I'm sorry. Maybe I'm really naive after 30 years of doing this. I don't know. But it seems to me that if you want to keep your job in the Trump administration, you do two things. You go on CNN, on CNBC, and you say how fabulous and wonderful he is, okay? And the second thing is you do what he tells you to do, assuming he hasn't changed his mind in the last 5 minutes. But based on the last thing that you have on your tweet, that's what you do. So what did that executive order say? The executive order said, don't implement any taxes, don't collect any of the taxes, basically back off from imposing the burden of this horrible, terrible, disastrous Obamacare. And also, by the way, now Secretary Price, if there's a regulation you can back off on, do that too. And oh, by the way, if you put a new regulation in, get rid of 2 old ones. And oh, by the way, don't put any new ones in for a period of time. And oh, by the way, don't spend any money because you have a hiring freeze. How are you going to staff 1,000 positions with a hiring freeze? That's a good one. Besides that, so even assuming that there are people who are professionals and functionaries at CMS, another very important thing you should hear from this conference, who are there, who know how to implement these policy initiatives, it's not clear that there are enough of them to get it done, who are on point on the agenda. And as I learned from my friend Cindy, sometimes when you run a state or government agency, the existing staff can work around you in very interesting ways to work against you, okay? People try that in my department, they're out, done. Message to team. But in government, it can work. So, my view is that, and you've already seen this, within 24 hours of the proposed rule that's trying to stabilize exchanges coming out, the IRS issues a notice that they are not going to withhold refunds from people who don't show proof of insurance. In other words, if the mandate ever was effective, which Lord knows it really isn't, but if it ever were, they're going to make doubly sure that it's not. So I wrote a little research note that started like this: left hand to right hand. What are you doing? Right hand says, oh, I'm trying to support the exchanges and make sure that they work. Why? What are you doing? I'm trying to eviscerate the mandate. Uh-oh. Okay? This is what we're dealing with. The other really key issue here is that it's not just the coverage. And when Anna was talking about this, that people don't understand what the ACA is. There's that whole big underpinning that deals with the catalysts that really have led to material change in outcome, in spending trends, in cost trends, in behaviors, in regulation, certainly of the insurance industry, and I would argue that prior to this they were a little bit giddy with their enthusiasm for gouging money from us, but now that's a little bit backed off. So it's not just the coverage, it's the money. So we saw some really good slides here about what ACOs were doing on the Medicare side. I have my own view about why Medicare ACOs tend not to show quite so much of a reduction in hospital utilization, because the health plan, it can't be a partner, but the hospital essentially must be or is. So why should the hospital empty out its own beds to benefit its ACO when it's not getting paid to do that? I've never understood. But when it's a health plan and a physician network, now you're going to start seeing some hospital utilization declines. And this is the biggest single thing I'm worried about for hospitals. So fewer hospital admissions in commercial ACO members. Even in Medicare ACO, they've been able to achieve a 12.2% decline in their ER visits. And 60% of heads in hospital beds come through the ER. Medicaid members, fewer hospital admissions in Tennessee, where they're running value-based models under TrumpCare, down 16.8%. Now, that doesn't compare with the down 40%. Congratulations to Landmark. That was really spectacular. Okay, but for this hospital population, even though, Tennessee has been in managed care for a long time for Medicaid, this is really interesting. So that's going on, and that's real. I'll point out one other thing to correct something that Joe said, because I can't have this without correcting Joe on something. He suggested that the reason that the health plans were on the exchange, went onto the exchanges to begin with, was political. And while that may be true for some, it actually was the opportunity, health plans don't like to miss new market opportunities, and that was the biggest single expansion of their marketplace since Part D, and it would be the last great one, unless we discover on one of those 7 planets that there's a whole new population eager to be covered under US health policy. But there was something else that happened, and this was fascinating. So total hospital discharges, this is from the American Hospital Directory, for all hospitals, including rehab, LTAC, and psych, but non-governmental, from 2011 to 2015, as reported on their cost reports, all hospital discharges declined from 35 million to 32.5 million over the period of time right in here where the ACA took effect. Okay? That's pretty stunning. EBITDA, so how well did they do? What's the impact of reform? EBITDA went in 2013, the year before reform went into effect, 85.8 million up to 95.6, and then down to 84.7. Because by the time 15 came around, you were already seeing not only this decline, so, you know, it's always about the volume and the cash flow. When you don't have heads in the beds, folks, you don't make more money. But by and large, you were still, you know, doing fairly well because you had this one really, really, really good year. Okay? This is the same data on this side shown in a picture. Now remember what I said, you don't want to buy charts that go down and to the right? You don't buy this chart either. All right? How long it's going to take for hospitals to ever turn this back up, not with everything you've heard this morning. So long as value-based care continues to be driven in the private sector and one hopes in the public sector by the non-evisceration of the only thing that's working out of the ACA besides the Medicaid expansion, this is what we're going to continue to see. So if you run a hospital, don't build a bed. That simple. Put it into other services, understanding how to treat your patients better, better bonding with primary care physicians, better artificial intelligence, because we're going that way. Do that. ER visits spiked and then are going right back down to trend. In the fourth quarter of 2013 for HCA, ER visits declined year over year on the same hospital basis. We're going right back to trend. So if they don't come in, they ain't going in a bed. There was something else that was interesting that happened, and this is important. The shift between Medicaid fee-for-service and Medicaid HMO and Medicare fee-for-service and Medicare HMO, so the managed flavor, okay? So what you saw was fee-for-service volumes decline and the managed flavor increase. All right, now we know that, you know, Medicare Advantage is what, 30% of people in Medicare? It's disproportionately sicker or older. Because it's cheaper, or poorer or older, excuse me, because it's cheaper. So we're starting to see the part of the population that's going to have higher utilization over time in the better, more managed product. That's important. But it also has an impact for hospitals because the intensity of service actually declines. And on Medicaid, it's described as this, that a Medicaid OB-GYN case, so a maternity case, the health plans are giving all kinds of, you know, clip this card and you get free stuff for doing prenatal care. So you're getting fewer NICU babies. And at $1 million a pop, that makes a difference in hospital profitability. So, so that's what we're seeing. And so this is the slide that I used last year. And I would say that the thing that has really changed even more than last year is that the whole notion of right care, right time, right place, for the right reason, at the right cost, is just accelerating. And what's happening now on the private sector side is the introduction, it's gone beyond big data, beyond data lakes, to artificial intelligence and deep learning, where predictive analytics are going to help us take yet another step in the not very distant future down in the cost trend. Because we'll be able to identify patients who are more at risk for conditions that would lead to high-cost hospitalizations and high-cost procedures, make them healthier sooner. And I'm not in la-la land on this, folks. It's happening now. And it's happening at places from, you know, executives and leaders that you heard here on the panel today, terrific panels. But more than that, it's happening because We've reached this point where we can now process the natural language that occurs in the medical record. So everything your doctor has ever put in there, we now have the processing capabilities and the intelligence with which to take that non-structured data and put it together with structured data and formulate a view of who you are, what's happening to you, what we can do to make you stay healthier longer. And that is very, very important. So last year I asked, is this the fee for value? And I said yes. And then the year before I asked if it was going to come. I said maybe. In 16 I said yes. And then this year, will the real price of Trump be measured not just in lost coverage, but in worse outcomes at higher costs? This is what it's at stake. Okay, now I don't care if some of this happened before or some of this happened after, but because it could have been 16 or 20% in 1990 to 2000. So to Joe's point, yes, costs were coming down. But the point is that the costs have come down a lot, and they keep coming down. And part of that is the leadership shown, forced on CMS perhaps, but certainly executed well by CMS in creating innovative payment mechanisms, whether mandatory or not. Okay, now I once said, you get what you pay for. I said this here, be careful what you wish for because you get what you pay for, all right? We're getting what we're paying for in the ACA. The hospital industry is paying $155 billion over 10 years. There's a Medicare, there's the health insurance industry fee, et cetera, et cetera. But what we're getting out of it for a society, and to some extent for a little lack of choice, we're getting substantial improvements in the outcomes, in our ability to live our lives, as well as in the cost to take care of us. So a couple of conclusions and recommendations. The question that I have is, will value-based care, which seems to be the direct antithesis of rising health care costs, continue despite Price, who, if you haven't read his version of repeal, you better, and Trump? And the answer is, well, you've got this colliding two trains. We got repeal and replace railroad over here with executive order express. We don't know who's driving this one. We do know what's driving that one. And that's where we are. So, in conclusion, I'm going to take 2 or 3 more minutes. I have to say this because the politics of this situation is part of what I think you want to hear from me, okay? And a reaction to the politics. And I'm going to apologize to my investor clients who are actually nice enough to join us today, because you're going to see a side of me you normally wouldn't see, but that's the game that gets played here. So, here we go. And over in the other corner as well. Thank you. So, first of all, this whole political discourse. I am very tired of hearing the Republicans, if not the conservatives, and Joe, I'm going to make them one and the same, and I'll apologize to you for that. I am very tired of hearing them say we whine, and I'm tired of them walking away when we start criticizing them. And I'm tired of being told that I'm an enemy of the people because I disagree with what the President of the United States says, okay? And if there are any of you who work in healthcare, who care one whit or iota about your patients and have seen improvements, then I think it's incumbent upon you, as well as me, to stand up and say who we are and define ourselves. Find a leader or leaders who will help us to work our agenda through the grassroots process into elected office and put an end to what may be the most damaging presidency we have seen in this country in a very long time. So I'm going to start, and I'm going to tell you who I am, if I can read. Professionally, I am a Wall Street analyst. I've covered healthcare services now for 28 of my 29 years on Wall Street. I was a federal government economist in antitrust and also for the Department of Labor, Death Valley. I am currently responsible for the care and feeding as Director of Research for Mizuho Securities Group, which, by the way, these comments do not reflect the view of my firm. For 25 other very talented professionals who give every single day their best efforts, and if they don't, I know it, but who do, in an effort to help investors to make money, professional investors who are managing your money to make money. And we never forget that. I am, I think, perhaps a healthcare and maybe even a little bit of a healthcare policy expert. I have succeeded in this career, but not alone. I first had support from my parents and family, then through the student loan process, because we didn't have two nickels to rub together, and the scholarships at Washington University, with help from mentors and the Olin Fellowship Program for Women in the Professions, founded by Ann Whitney Olin. I have teachers, I had professors, I have had employers and bosses and friends, and finally, I could not do this without the help and support of my family, especially my husband, to be here, to be successful. You can't do it alone, and I firmly say that. But when you are successful, despite the fact that I'm a capitalist, despite the fact that I believe in the right of people to make money and not be ashamed of it, I also would like to think of myself as a compassionate capitalist, that I didn't do it alone, and it's my responsibility, it's a moral obligation to ensure that the world is fair enough for others to be able to do it on their own, and with a little help as well. In addition, I cherish the freedom that was granted to me by the Constitution of the United States. I accept its responsibilities. Part of that responsibility is to make sure that we create an environment for citizens, for immigrants, and for those legally and to some extent illegally here, to the right of due process as required by our Constitution, and if not, to at least compassionate exit. It is very important, I think, that we all understand who we are, where our moral compass is, and stand up and say what we think is right, and to find and to create leaders who understand this. I know that it's important, in my mind, to do no harm and to speak up when harm is done to others. I am also the granddaughter of immigrants. I am the mother of an immigrant. These issues are very close to me. I am also the mother of a son whom you've met, many of you, who is now a senior at Northwestern University, who has decided to pursue a career in intellectual property and patent law, and I'm delighted to say may come to University of California at Irvine to attend Irvine Law next year, as he's been accepted by this terrific institution. As I said, I believe in our Constitution, and I will fight to defend it. I thought about leaving. There are some who would say that because I stand for the right of immigrants to come here to seek the freedom that we have, because I stand for courts and a court of law and a nation of laws, because I stand for a moral position that includes compassion for others who may not have what I have, that I am not a patriot. We can no longer allow others to determine who and what we call ourselves. Others do not have the right to say that I am not an American and that I am not a patriot. We need leaders who understand that to allow the other side to define the fight, whether it is on healthcare or patriotism or on what defines a human being, is not acceptable, must be changed. It must be changed now and from the bottom to the top through the process. We need leaders who will step forward. If it is not the current leadership of the Democratic Party, then we will find another. This is what I pledge to you today. This is who I am. The fight starts now. I thank you for the opportunity, and I apologize if it has offended any of you, but this is an important thing for us to believe and to say. I fight for the health care of others, for the right of the free market, and for my child to grow up free and safe here at home, a citizen of the United States. Thank you.
Thank you, Cheryl, for quite an emphatic conclusion to this wonderful conference. We do have about 5 or so minutes for questions, and I think we learned today that there are some value-based things that are working. There are some partnerships that are showing promise, that there's a lot of uncertainty what's going to happen in our legislature, and that we have a lot of work to do to ensure that all Americans get excellent, high-quality, affordable health care. So thank you, panel, for that. So why don't we open it up for 5 minutes or so of questions, if you have any. Yes, ma'am.
Let me just make a comment. I really enjoyed Shelley, always. Very dynamic speaker. I will address that to you. I read on the Becker's Hospital Review, I think, with this, if this repeal of the Obamacare, the ACA, there is a projected, 6 billion losses and bankruptcies affecting a lot of hospitals. And I thought there might be some kind of explanation. I kind of sense a little bit of it because of what you just said now, with all the explanations there. But in the meantime, with all the chaos that we're having, we are so dedicated, I could see from a lot of healthcare professionals, and I strongly believe that. But with all this chaos, everything is all like negative in the healthcare environment. How do we cope on all this? Because we are not looking at how we're gonna be, because the culture is being redefined right now with the society, as you kind of touched that. But how do we cope? And we need the hospitals. It's like for emergency. There will be few that will be left, I think. But how do we cope? This is, I need some kind of moving forward, of forward thinking here, sure, so we can adjust. We cannot just wait for the repeal and let Donald Trump do all these executive orders. We have to do something, like just on the personal level. Everybody's coping to this kind of,
Yeah. Am I on? Yeah? Okay. So thank you for that. The first thing I would say that, if you have a position, and if your position is that it should not be repealed, whatever, you need to call Congress frequently, daily. These calls work. You call your representative, you call your senator, you let them know, you speak up. Anybody can call, everybody can call, and you say, I'm calling for this position. Whether you're for it or against it, it doesn't matter. Everyone has the right to call because Congress works for you. That's the first thing. The second thing I would say is within healthcare and within the healthcare situation, industry, one of the things that we can do is, there's not a whole lot of a lobbying voice going on there. There is some, but I didn't hear a whole lot about, the American Hospital Association making noises, don't do this, don't do this. And part of the reason is that there are some hospitals who are actually losing money on the exchange patients. Okay, they're actually because of the $155 billion in cuts, and the dish payments are going down. So there's a real mixed emotion, so you can't really depend upon the lobbyists. But I would say that what you need to do is to make sure that you're working the political process, because this is a political problem. It's an economic problem, yes, but it's also a political problem. And if you can't work through the political process, then the one thing I would say is that you have to make whatever small changes you can make. So if that means working to get someone employed so that they have employer-based insurance, or helping in any way that you can do that, helping to make the healthcare system more efficient and effective so that perhaps if you work in it, as the costs go down, some of these problems may go away. If we were treating people really well and we had a really effective, efficient cost system, we could probably afford to provide care for more people with limited Medicaid dollars.
Thank you. There's a question over here.
Again, as a medical oncologist treating cancer patients, I can tell you what happens between the provider and the patients. Even though we're not supposed to, we are the only partner of the patients in the struggle of securing health care. So we constantly are asked, and I've seen a real impact. You've seen the impact on your slides what the election showed, but I saw the impact in the clinic side with patients' blood pressure going up, anxiety levels skyrocketing, patients that are on the ACA extremely scared being on active chemotherapy, being interrupted, not getting therapy. They're getting advice by me already to look into alternatives way before Congress decides on anything. So it has a real patient impact, and it has brought patients and providers closer to be partners in trying to navigate this from that perspective. Physicians and payers, we have trust issues, but physicians and patients, we usually don't have trust issues. So we're using that to protect our patients against what's happening politically, regardless of what's happening on the left or on the right, which it really has made our job so much more difficult, because we're spending time, instead of me teaching you about your cancer, teaching you about how to navigate your healthcare arena, teaching you how to get drugs covered, how to mobilize the entire staff in the clinic just to get you through your treatments. And so less and less time is offered for your treatment plan and for your navigation plan through the healthcare sector. So I want to make sure I mention that, because this is an active problem of all physicians, I think.
Thank you. Are there any other questions? We have time for one more question up here.
Thank you. My question is for Mr. Michelson. How will we get through this? You're saying that there's going to be a dance card where the payers and the providers will pair up, and we get to the Eindhoven endgame that Dr. Margolis mentioned. But in the short run, even at Inova in Northern Virginia, most of their business is being paid for by the blue plans, Anthem and Care First. So how do they turn their back on that payer in order to embrace Aetna as their partner in innovation? And everywhere in the country, there are these, dominant payer relationships that are the lifeblood of the health system's revenue. So how do we get through the process to these married couples that you have in mind?
Cousins, maybe. Yeah. So it's a very complex question. So I see the world. I'm going to make it more simplistic than it is. There are two versions of healthcare right now in terms of market structure. There's a version of the world where there's a big blue plan that has 60 or 70% market share, and there are a lot of those. And in that environment, there are often, kind of conglomerates of health systems and payers, sometimes of greater size and scale. And then there's a version of the world where it's a more fragmented payer environment. The irony is that from an antitrust standpoint, the bar for what a monopoly looks like on the payer side is a lot higher than it is on the provider side, but that's a separate comment. But in any event, in version 2 of the world, that's where you see a lot of the more innovative partnerships occurring, right? Which reflects on, Aetna and so on and so forth, and Humana and Cigna, and where blues are in kind of a more competitive dynamic. Where you have an environment where it's a big system and a big payer, which is, I think, what you're speaking to, you're really asking two behemoths who need one another to have a very different relationship. And in that environment, what I've found is that you can't bring your whole business to the middle of the dance, right? If you try to go through the middle of your commercial model first, someone will flinch. And in those instances, you actually have to go where both organizations are struggling. And in many instances, it's going to be Medicaid, where there are social issues. It's going to be Medicare, and actually partnering to help convert more of your Medicare fee-for-service business, which is nationally at 30%, but in some markets less. You can actually partner with the blue or another payer to kind of move it. And then we'll see what happens with the exchange population. The other is going to be, how do you think about kind of carve-outs within your commercial population for your more high-risk your higher risk kind of portion of the pyramid, and we've seen that too. So I don't think it can be a monolithic answer. I actually think you have to take a funding segment approach and say, where do we kind of win together, and where do we have to kind of figure out a glide path, which looks different than a different market structure.
Well, in conclusion, thank you all, and please, let's thank our panel. Now invite Paul up to make some concluding remarks. Thank you all.
Well, I'll be very brief. I just want to thank you all for coming. I want to thank all the speakers and the ones in the overflow room too. And as I do always in the last session, I really want you to join me in thanking the one who's really done so much to make this conference a success, Margaret Wong.